Okay, I think we're going to get started. Everybody's ready. We'll do the recognition of quorum, and we just have James absent. The other 6 are here of the Board of Trustees, so we'll recognize that. Next, we'll go through the consent agenda. Is there any questions on those 4, A through D? Anything on the payroll claims, credentialing, meeting minutes, or agenda? If not, can I get a motion for that?
I'll make a motion to approve the consent agenda.
I'll second.
First and a second, all in favor?
Aye.
Opposed, same sign. Motion carries. Okay, now we got Jeremy here with Ide Bailey to talk about the financial audit report.
Perfect, thank you. So in front of you, you have a copy of the slide deck here in case you want to jot down some notes. Yesterday, we had about a 30-minute meeting with the Finance Committee, went over some of the numbers in detail. We'll try to keep things pretty high level for you here. My intention is to walk through the hospital results as well as tell you about what I'm seeing with my other critical access hospitals here in the state of Iowa. We have draft financial statements and draft report to the Board of Trustees. I put everything up on these slides so we're not flipping through a bunch of different reports all at the same time. So what's my responsibility as an auditor? It is to obtain reasonable assurance that the financial statements are free from a material misstatement and then express an opinion on those financial statements. Just like years past, we have a qualified or sometimes referred to as an except for opinion, basically saying everything in your financial statements is at the highest level of assurance we're able to give on a set of financial statements, except for the fact that SCMC is not consolidated within your financial statements. You have 2 separate organizations. You have the hospital and the SCMC. According to governmental accounting standards, those are supposed to be consolidated. We just have the hospital financial statements here. So we're just telling the readers that there's another entity out here that is not consolidated in, which would very minor changes to your financial statements if that were to happen. And we actually disclose those amounts, how much the assets would change, how much the liabilities would change, et cetera, if this truly was fully consolidated. We did have a handful of audit journal entries here. The only ones here that are very significant in nature is the accounts receivable allowance and the Medicare cost report settlement. I get the benefit of hindsight. At year end, Christy has to make some estimates and judgment calls in terms of what she thinks the Medicare cost report is going to look like at the end of the financial statement audit. I get to come in and actually prepare the Medicare cost report, so I actually know the number. So we did have a small journal entry here to do some adjustments to your accounts receivable allowance and your Medicare cost report. The rest of this was kind of clean up journal entries. When I bring these all together, as your auditor, I'm required to talk to you about any material issues that I have. I don't have any real concerns about these audit journal entries. So there's a handful there in numbers, but none of them are real significant in nature that give me a lot of concern. We do also have one uncorrected journal entry. This is an item that from the Medicaid Directed Payment Program, they make you some interim payments, and then after a 9-month look-back period, they do a final calculation. We do believe that you'll have a little bit of a payback situation for the 2025 Directed Payment Program, but it's not enough for us to request that your team make an audit journal entry to recognize that liability. In terms of accounting standards, your team is supposed to draft the audited financial statements, the financial statement footnotes, that whole 70-page financial statement. Nobody does that. So this is a comment to the board that our team, as your auditor, prepares those financial statements, gives the drafts to your team to review and approve. The fact that we do that and there are some audit journal entries, we kind of bundle those together and we call those material weakness. Am I concerned about that? Absolutely not. That's pretty common. Also, segregation of duties as a significant deficiency. You're a larger critical access hospital. Even our largest critical access hospitals have segregation of duties issues because you're never going to fully employ enough individuals to segregate all your duties across the finance realm. So this is just a reminder to the board that you do have some segregation of duties there, and you have an obligation to review the financial statements on an interim basis, ask questions to Christy and her team, and making sure you're getting back proper responses. A couple of things that I see as well going on in the industry: county tax revenues and the Medicaid Directed Payment Program. Let's look at county tax revenues. There's 83 critical access hospitals in the state of Iowa. 41 of those are governmental entities and receive some amount of county tax revenues. At the bottom there is your facility in blue. the median facility in the state of Iowa, and then the average levy in the state of Iowa for those 41 critical access hospitals. I bring this up because you can see year over year, everyone seems to be drawing a little bit more on their county tax revenues, where your organization has held that line pretty consistent year over year over year. So as a board member, if and when you might have a comment from a community member or a county member or whatever the case may be about county tax revenues, just remember your team and your facility doesn't draw nearly as much as other critical access hospitals in the state. I think that's a pretty powerful message. All right, the Medicaid Directed Payment Program, just a reminder of what that is. Effective July 1st of 2023, the Medicaid Directed Payment Program went into effect for the state of Iowa, which basically gave some extra reimbursement for Medicaid patients. So HR1, or the One Big Beautiful Bill, put some restrictions on the Medicaid Directed Payment Program, and the biggest one being the second one here. It caps the amount that you're able to get as an add-on payment at 100% of the published Medicare rates. Iowa is currently at 130 and 194. So at some point, because the state of Iowa is a grandfathered facility or a grandfathered state, starting 7/1/2028, there is going to be a ramp down from this 194 and 130 down to 100%. So this isn't the exact number, but at some point between 7/1/2028 and 2023 or 2038, your reimbursement underneath this program is going to get reduced by about 50%. Just high-level numbers. And last year, you received about $5.2 million from the Medicaid Directed Payment Program as add-on payments. So that number will likely be cut in half at some point between 2033 and 2038. Now, while that sounds bad, remember, this program started 2 years ago. So it's not like you've had this for decades. Fiscal year 24 and fiscal year 25, the first years your facility received these additional funds, okay? So I want to make sure and make it very clear to the board that it's good that this program is going to stick around, but the reimbursement impact is going to go down by about half. And then we just don't know how slow or fast that's going to happen. If it happens really fast, you're going to lose 10% in 29, 30, 31, 32, 33 to get to that 50%, or you're going to lose 5% if it goes slow. But somehow you're going to get to about that 50% reduction in that particular program. Now, some of the pushbacks under the One Big Beautiful Bill was this reduction in state Medicaid Directed Payment Programs. So what was written in was this $50 billion Rural Stabilization Fund, which is kind of two components as well. 50% of those dollars go to every state on an equal basis. And then the other 50% is kind of grant-based. So the state of Iowa, here in the next week, week and a half, is going to submit their plan to the federal government for their other piece of that 50%. They're going to know by the end of the calendar year how much they've received, and then start talking to facilities about, okay, what do you have to do, what metrics do you have to meet to receive access to that other 50%. I fully expect the state of Nebraska, Iowa, Kansas, Missouri, there's a lot of rural health care in those states, so I expect them to get a pretty good chunk of that extra $25 billion. But we're not going to know until the end of the calendar year. So that's kind of a more to come kind of comment. Let's dive into your financial statements. On the asset side of the statement of net position or your balance sheet, I highlighted in blue, these are your cash, your investments, your assets limited as to use. Last year, about $22 million, billion would be nice, $14.7 million this year, about a $7.3 million reduction. Where did that cash go? Capital assets, obviously you have your project going on, you added $14.5 million of capital cost to your organization here in fiscal year 2025. On the liability sides of the balance sheet or statement of net position, in blue are your long-term obligations. Those are your traditional debts, your long-term lease liabilities, and your long-term subscriptions for IT software. For the first time in a long time, you actually do have traditional outstanding debt. In 2025, you entered into a $10 million note at a 5.9% interest rate, and you drew $1 million on those funds during 2025. So for the first time in a long time, you actually have something here in this long-term debt part of your liabilities. The difference between your assets and all these liabilities is your net position, an increase in your net position of about $6.3 million here in fiscal year 2025. How did that happen? That comes from the income statement, the statement of revenue, expenses, and changes in net position. Good top-line growth here on your revenue side, 11% increase in gross revenue. Some of that's price increases, the rest of that's volume increases, primarily in radiology, your clinics, psych, and pharmacy. I see a lot of those growths happening in my other critical access hospitals across the state. The other line item that sees a lot of growth here in 25 has been ER, emergency rooms. Your facility didn't have that growth here in fiscal year 2025. 340B is primarily the increase here in your other operating revenue. That's a drug discount program, some additional reimbursement for the facility for 340B. So good top line growth here for the revenue. Now with the additional volumes and additional 340B activity, you're going to have some increase in your expenses. A lot of those expenses are sitting here in that other expense line. But when you take your revenues minus your expenses and we get to your operating income, $2.1 million last year, $3.8 million this year. A lot of that growth is from the DPP program, that Medicaid Directed Payment Program, and your 340B program. Add in non-operating revenues, things like county tax revenue, your investment income, those sorts of things. Add it all together, $6.3 million bottom line this year, $5 million last year, $4.4 million the year before. So good trending here for your income statement the past 3 years. So now I wanted to look at a couple financial indicators. We're going to have your financial statement. We're going to have the other 15 biggest critical access hospitals in the state of Iowa, and then the median of the 83 critical access hospitals in the state of Iowa. So kind of you and then two peer groups. The peer groups are always a year behind because it's based off of filed Medicare cost reports, which clearly we haven't filed 25 yet. So we're always a year in arrears. It's always important as a critical access hospital to know where your revenue is coming from because not all payers are created equal. We would prefer to have outpatient commercial volume because Medicare and Medicaid in theory pay you cost. One of the big trends that's going on in the not only state of Iowa but all states is the increase in Medicare Advantage. It's a bad payer. They do line item denials, you have to do a lot more pre-authorization work, and even when you jump through those hurdles, they're slow on their payments. And when you file a Medicare or Medicaid cost report, there's a settlement at the end. They true up to you based off of your final costs. Medicare Advantage doesn't do that. So when you're in a rising expense situation, you might have a receivable from Medicare. You have about a $400,000 to $500,000 receivable from Medicare right now. Medicare Advantage isn't going to pay you any more for those services. So you're getting paid less than cost from them. Bad payer. Now we talked about this in detail yesterday at the Finance Committee, but I will tell you that other critical access hospitals were seeing 20 to 30% growth in their Medicare Advantage plans in 2025. Yours was, while it did go up, not nearly as much as some of your peers. And that is a good thing. So the majority of your growth happened in the Medicare side of things, 12% increase. The other biggest increase is Wellmark at 17%. I want to show you why that matters. This is your write-off percentage. So Medicare, Medicaid, Wellmark, all writing off about the same, basically 50 cents on the dollar. But when I have a commercial payer come in, I only write off 37%. So there's a 12, 13% spread there on the commercial volume, where that's your opportunity to make a margin in a hospital. All right, so total margin. Fairly consistent amongst the years here for your facility. Not surprising in 23 to 24. Most other organizations saw a big pop in their total margin because that was that first year, that extra Medicaid directed payment program. I will tell you a lot of my critical access hospitals saw a decrease in their total margin here in fiscal year 2025, while your facility actually had a bit of a growth in 2025. Days cash on hand, this is taking all those blue balance sheet items that we were talking about, the cash, the investments, the assets, liabilities, the use. I take your income statement, back off depreciation, because those are expenses we've already paid, those are assets we've already bought in the past, they're just depreciating. Take that number divided by 365, and your facility spends about $170,000 per day. Take that divided by the cash that's on the balance sheet. How many days can you stay in operation without additional patient service revenue, county tax revenue, additional receipts? 88 days here in fiscal year 2025. We talked about why the big decrease is because you have a lot of costs for that capital project. Your dollars came out first, and now you have a note payable out there for any additional dollars going forward. So I think that number is probably plateaued here, and going forward will probably work its way up with additional Medicaid directed payment programs, et cetera.
How long will that, do you know any idea how long that'll take to get back to that?
Well, let's say Medicaid directed payment program was, what, $5.2 million divided by 170, that's $30 per year, or 30 days of additional funds. So if you're not spending that on the capital project here in fiscal year 2026 and all things remain equal, you would increase 30 days just from that Medicaid directed payment program here in fiscal year 2026. Good question. Net days in accounts receivable, this is a revenue cycle metric, basically saying how long does it take your facility to turn a claim? You know, I walk in the door, your business office processes it. How many days does it take from me leaving your facility to actually getting cash in the door? 50 days. Fairly on par with the other bigger critical access hospitals, a little less than the smaller critical access hospitals, but they have less service lines, they have less volume, it's a little easier for them to get their hands around things. You're right on par with your peers here. Outpatient revenue percentage, this is actually a good thing. We want as much outpatient revenue as possible. Inpatient's a really high cost per care center, so we want outpatient commercial volume. So step one, outpatient volume is increasing, that's great. It's only going to increase more once the rural health clinic project is done and you have more space there, you can bring in some specialists, those sort of things, that number is going to continue to climb. That's a good thing. Now, what we want to see is this number here, the Medicare outpatient payer mix. We want the Medicare number to go down because in theory that's going to get replaced by commercial volume. That narrative has changed quite a bit with the additional Medicare Advantage. I'm seeing people's numbers going down on the Medicare outpatient side, but it's getting replaced by a worse payer, not a better payer. So the fact that we go back to that first slide where I showed you where the gross revenue is coming from, you did have a significant increase in Medicare revenue in fiscal year 2025 and then Wellmark in 2025. So Medicare is a little bit bigger piece of the pie in 25 than it was the year before. But not a terrible thing. Good slide here, Medicaid cost to charge ratio. This is basically showing me what does it cost in the outpatient setting to provide care. So last year, if I had a $100 charge, it cost me $45. This year, if I had a $100 charge, it cost me $46. Again, right in line with the other bigger critical access hospitals, and quite frankly, in line with the smaller critical access hospital because they have fixed costs, right? You have to have nurses on staff, even if I don't have a patient in a bed. My cost is there. It's pretty fixed in relation to their volume. So again, kind of a non-issue slide there as well. Great slide for the hospital debt to capitalization. If you're thinking of just traditional debt, years past this number was 0 because you didn't have true long-term debt. You had some leases and you had some subscription-based contracts. This year you have a little bit of additional true debt, but still with that, you're not a highly leveraged facility at all compared to some of your peers. And in addition, you have a fairly young, quote-unquote, facility. This is depreciation divided by accumulated depreciation. You get a feel for what's your average life on the books. That number is only going to go down in 2026 as that project comes online and starts spitting off depreciation. So you don't have a ton of debt, and you have a fairly young facility, so that's telling me in those years past back here, you were putting money back into buying assets at about the same clip as they were depreciating. Where some facilities that are sometimes in a cash flow crunch, which your facility hasn't been, that number continues to climb as it depreciates faster than they're actually putting money back into the hospital. All right, I promised Christy I'd try to be fast. I felt like I talked really fast. So let's open this up for questions, comments, concerns, anything I can answer for your team.
I'm very impressed. Good report.
I didn't thank Christy. That was the first thing on my sheet. Thank you to Christy and her team. Audit went very, very smooth, always well prepared. And then when we're on site and we ask questions, her, Keith, the rest of the team, they get us answers back right away. So hopefully, I'm hoping by the end of the day to have your Medicare cost report ready to file. That's not due until the end of November, but you'd have a decent sized receivable there, so we want to try to get that into Medicare's queue as quickly as possible. If not today, we'll probably get that filed tomorrow. Again, a month ahead of schedule. A lot of it has to do with her team and getting us information to file that cost report.
Great.
Questions on numbers or anything like that? Okay. Well, if a week from now, a month from now, 6 months from now, whatever, second slide there is my contact information, phone number, email. Shoot me a call, give me an email, whatever. If you have questions, I'll talk you through it, and if I don't know the answer, we'll find it for you.
Awesome, thank you, Jeremy.
Absolutely.
Can I get an approval for the, I guess it'd be the financial audit report from Jeremy and Ide Bailey?
I'll make a motion to approve.
Second.
First and a second, all in favor?
Aye.
Opposed, same sign? Motion carries. Okay, thank you, Jeremy.
We're gonna go out in the rain for a while.
All right.
Thanks, Jeremy.
Thank you.
Sure.
All right, next we got the quality improvement report by Laura.
Okay, our last system-wide QI meeting was on September 17th, and we had 17 departments report at that. So this report is just an extension of that from the last meeting. OB reported no primary C-sections, which is really great. I think we've had a couple quarters over the past year that have hit that with no primary C-sections. Our delivery numbers are going up, and that's really going down, so that is great news. There was no OB or newborn complications reported. Outpatient services monitored after visit summaries, hand hygiene, and kit count documentation for their OB patients, as well as imaging scans for low-risk surgeries. They want that to be a low number. We don't want to be doing or having radiology procedures for surgical procedure. So that was at 2.1%, and the national average is 2.9. So we want to be below that. Pharmacy reported no adverse drug events, and there was an antibiotic team meeting in June, which is really a multidisciplinary team that meets 4 times a year. Rural Health Clinic reported on the ACO measure. 75% of our patients have breast cancer screening done appropriately, and 87% of diabetic patients have a controlled A1C, which is really great. It's almost at 90%. Senior Life Solutions monitored medication reconciliation and physician signature within 5 days of having their patients seen, and that was at 100%. Surgery reported no post-op sepsis and collaborating with infection prevention on testing surfaces for any bacteria, and that is going very well as monitoring consent documentation and post-op phone calls. Utilization review reported 100% of appropriate level of care, length of stay, and monitored readmission rates. And also social determinants of health is a new measure that they've been monitoring for all inpatients, both OB and med-surg. So they're looking at that and reporting that as well as if there's any positivity, what we're doing from that standpoint as well. So overall, a good report.
Awesome, thank you, Laura. Next we'll go to administrative reports. Chief Nursing Officer Nicole.
So the medical staff met on October 14th. Masking recommendations were reviewed at the request of Kathy Beeman, our infection prevention nurse, and we did change some verbiage in there to mask use is highly encouraged when caring for the immunocompromised patient population. And we also adjusted our recommendations. So team members, after a positive influenza or COVID test, they are able to return to work when they're fever-free for 24 hours without the use of medication, and their symptoms must have improved as well. So the medical staff approved those adjustments, and we did make those facility-wide. Jason Eckerman came and talked about an NT-proBNP lab test, which just is a minor adjustment for a testing that we complete for those patients that might have some congestive heart failure. So we discussed normal lab values, and that is now implemented within Epic. The state hygienic lab test results are now interfaced in Epic, so rather than send the test results out, wait for the fax to come back, upload that into Epic, it just talks. So as soon as the testing is done, it's interfaced with Epic and we can see the results. We reviewed the inpatient order set and made some minor adjustments to that for sepsis. Dr. Brian Anderson did some education and discussion on the utilization of Epic macros, which is just something nice for the providers to be able to use. And he provided some tips and tricks on how to do that. Claire Cron agreed to be an Epic super user for us, so a physician champion in that regard. So she'll do that a couple of hours a week and work with our Epic support team. And we had a successful Epic upgrade in October, and Mary Peterson reported on that. That's all I have for today.
Awesome. Any questions for Nicole? If not, we'll move on to Kim, the Chief Clinic Administrator.
Sure. Construction continues. Things change daily over there. There's a whole lot more color up on the wall, which is great. The elevator has been down. We're in week 4 at this point, getting all of its updates and just kind of getting that overhaul. Talking with Drew this morning, they're waiting for a few more things, and then he'll give us kind of a projected time frame when that will be back in business. Really, that's the only thing that affects any of our patients within that space, just because we are on the 2 levels. But things have gone well. We've got a lot of team members who are more than willing to help people find their way, so very appreciative of that. Otherwise, yeah, lots of changes since you guys did the walkthrough. We'll plan for open house when everything is kind of finalized, and we welcome everybody to come in and check out the new place.
Are you still kind of looking at that first week in December, that?
Yeah,
There's a few-
at a high level, we take, significant completion will be done on November 14th.
Okay.
What that means is that it's close to being ready to open. There'll be a punch list that'll be created after that. They estimate about 2 weeks worth of time to get that. We take that same 2 weeks. We have to install all the computers, monitors, the printers, stock all of the cabinets and the drawers, everything in each of the exam rooms. We also, behavioral health is going to be moving over, so we need to pack all their stuff in the other building, bring it over, figure out the plans on that. Since the first time, if Friday was our first significant completion target date, we had a change control that pushed it back to the 14th, but we would have approximately 2 weeks to do all of that work. Now it's going to be approximately 3 weeks, because right in the middle of it is Thanksgiving. So you have the Thursday and the Friday, there's probably not going to be a whole lot of people around, so that's what we right now have tentatively planned, is that first week of December for an open house, and then the following Monday potentially as the grand opening. But that's up for discussion internally to see if we can get all that work done in time or not. It may move up, it may
Right.
hopefully stay the same.
Nice to have a goal, though.
Yes, absolutely.
So what was the answer? December?
Yeah, right now December 5th.
Yeah, we'll communicate and get that out, to the public and everything, inviting folks in to be able to see the new space, just like we've done with the other departments, so.
Yeah, well, the open house, the ribbon cutting, Chamber of Commerce will be there, so.
Cool.
Awesome. We're excited for that. Thank you.
So are we.
I bet.
Excited to be done, probably, yeah. Chief Human Resource Officer, Jill.
Yeah, so last week, we offered all of our leadership team, all of our managers and directors an off-site, kind of an interactive leadership development session off-site. We try to do that a couple of times a year. And this year, we brought in a third-party facilitator who was recommended from Iowa Hospital Association to really focus on customer service and aligning that with accountability discussions and trust between teams to really elevate the patient experience. That's what our goal and focus was. And that conversation really aligned with the topics of conversation that we were hearing from our strategic planning sessions that we had in the spring. So she did a really nice job for us last week. We are surveying all of our leaders on that to see how they like that session and what we can be doing better going forward. So I wanted to make you aware of that. We're also in the middle of our performance evaluation time frame cycle. So all of our department managers will be evaluating staff between now and kind of early December in anticipation of January 1, when we issue awards increases for both performance, merit, and market. And then I'm also going to go over the health plan renewal for next year. I think, unless you want to tell me to go forward with that.
You're good. No.
Go ahead.
Okay.
Sorry.
So we are getting ready to initiate open enrollment. So it's the time of year that all of our employees enroll in their health plan, dental, vision, and ancillary benefits for the following year. I like to show you guys our net hospital costs and our trends year over year. What you're seeing are the last 5 years of trend, and so increases have ranged anywhere from like 9% year over year, all the way up to almost 14%. Going from 2025 to 2026, we are anticipating a lower net hospital increase, and I'm going to talk you through how we're able to accomplish that. So between this year and next, we're really looking at a projected roughly 5.5% increase. That's to the hospital. So in looking at the claims data, last year, Myrtue engaged with the multiple employer welfare arrangement, so the RICHA group. So 8 other hospitals are part of this group. All of our claims trends go together within that group, with the intent of kind of lowering costs overall for all of us. The overall RICHA group trend is about 8.5%. Myrtue is trending higher. So our utilization, our claims data is trending higher at 10.7%. Had we not made the changes that I'm going to recommend today, we would have seen a 10.7% increase. But we're projecting anyway that they'll stay at 5.5% as a result, which will also remain within our budget of 6%. So we came to the board in the spring, budgeted for 6% health insurance increases, and this is how we intend to kind of stay within that. So our PPO Alliance Select Plan, it is the most costly plan. Subsequently, it also has the highest number of plan members in that plan. At the start of 2025, we did introduce some new state-based provider point of service plans with the intent of lowering costs overall. So these plans, they're really focused on providers specifically within the state of Iowa, which affords us greater negotiated discounts. It does have a solid provider network. The plan coverage on those point of service plans is nearly identical to the traditional PPO. That is our most costly plan today. And members are incentivized to receive their preventive care within Iowa under these point of service plans. Another point of differentiation is that under the point of service plans, chiropractors are not covered. We were less concerned with that just in terms of how plan members kind of utilize that benefit. A lot of people utilize chiropractic services and pay out of pocket at point of service. So we were less concerned with that driving our decision on whether to keep our highest cost plan. So with the goal being cost containment, really, we are recommending eliminating our highest cost plan, the Alliance Select PPO. And in doing so, we're comfortable and confident that all of our plan members have the opportunity to shift to either an equivalent cost, lower cost, or slightly higher cost plan, just depending on what they choose. So we're going to continue to offer 3 different plans. One of them being kind of a nationwide network, the other 2 plans really being focused on the state of providers within the state of Iowa. Myrtue is going to continue to cover about 75% of the total medical and dental premiums that are incurred. Our prescription drug carrier will change, so employees will see a change and we'll communicate that to them. But we anticipate that to be seamless. So if they're currently using CVS pharmacy, we're gonna move to Express Scripts, and if they have active scripts, we're gonna automatically transition those to Express Scripts. With the changes that we made to the health plans and able to keep a lid on costs, Myrtue is able to increase their health savings account contribution. So those individuals in a high deductible health plan, they have the ability to also have a health savings account to help offset those medical expenses. Myrtue is going to increase their contribution to those accounts. So $700, up to $700 for employee only, up to $1,100 for employees plus their spouse, and up to $1,400 for employees who elect family coverage. So as far as additional benefits, since we're really focusing on medical and dental plan costs, the additional benefits that we provide really are not changing. So pre-tax medical flexible spending accounts, we will continue to offer that to employees, and those are compatible with those point of service plans that we offer. The contribution limit, and that's an IRS contribution limit, not a Myrtue, that does increase to $3,400 for our employees. So you can put funds, yes, into an FSA pre-tax to pay for your medical expenses. Similarly, the pre-tax dependent care FSA, the IRS is increasing those contribution limits from $5,000 to $7,500. So that's really important to our team members. We hear some about the need for childcare. This just gives team members the opportunity to defer some of their earnings pre-tax to pay for those expenses for child or elder care. So dental and vision will remain unchanged, meaning the coverage will remain unchanged. The carriers will also remain through Delta Dental and VSP. We are seeing that dental claims have gone up a bit, about just shy of 8%. So those premiums will increase slightly for employees, but when you look at the actual premium increase, we're only talking 50 cents to just under $2 per pay period increase for that coverage. And then life insurance, accident, critical illness, cancer, hospital indemnity will remain with Symetra. We've had really good luck with that carrier. They're very responsive, provide good customer service. So those plans will remain unchanged. So in total, when we look at our total medical and dental costs, medical to the hospital, the net costs, we're looking at just short of $4.3 million. Dental costs will go up to roughly $130,000. So in combination, we're looking at a total of $4.4 million. So what I'm requesting is approval to renew with the medical plan changes that we've discussed to keep those costs where they're at.
I just had a question on the HSA side. Those contributions that Myrtue makes, are they a one-time contribution like the $700 to $1,100 to $1,400? Is that a one-time contribution that we make to the HSA, or is that annual, or how does that?
We do front load some January 1st, so we'll front load a bit of that total, and then Myrtue will match. Basically, it's like a 50% match throughout the year. So the employee has to contribute and have skin in the game on some, and then Myrtue will match up to those numbers.
And are those matches in this 4.4 million? Any of those matches, or an estimation of those matches are in that 4.4 million?
Yes, Myrtue's total contribution to the HSA is included. Yes.
At the maximum matching point.
Yes, up to the maximum matching point, yes.
Have you unveiled this to the staff yet?
No, they will receive this information very soon, so we're gonna hold education sessions starting next week. So we'll have like employee forums as well as one-on-one sessions with employees to go over their enrollment elections if they have questions.
What's the percentage of PPO people that you have in the books?
We have 155 total enrolled in that PPO right now.
Okay.
that will migrate out of roughly 260 who enroll. So quite a few.
That's a lot.
Yep, quite a few. The good thing is that, like I said, their coverage does not change. If for whatever reason they want to see like providers for their preventive care outside of the state of Iowa, we have those
They
plan
got an
options
option.
available. It's an option.
From what I read,
Yeah, the provider network is quite good, not only in the state of Iowa, but in the contiguous counties surrounding Iowa. So, we've done an evaluation of the disruption, the potential disruption, and not seen that to be a major inhibitor to moving to this, so. Okay.
All right.
I'll move the approval of the 2026 medical and dental renewal.
All right, we got a first, I got a second.
I'll second that.
First and a second, all in favor.
Aye.
Opposed, same sign. Motion carries. Thank you, Joe.
This was a lot of work, Joe. I appreciate
Yeah.
it. This was a lot of work. I appreciate all your effort here. That's a big change.
There might be some ahead
the
too.
key is the
Yeah,
time.
there's a lot more.
That's the big thing.
Yeah.
I mean, that's the issue every year, it just continues to increase.
Yeah, good point. Yeah, we wanted to make sure the impact was minimal, and in most cases, you're gonna see a reduction in premium, if not a slight increase, depending on what plan you choose. So,
Awesome. All right, Chief Information Officer Jeff.
Sure. A few things on the IT side. We have started the upgrade to Windows 11 for all of our computers. Over the weekend, I think we got all of the first floor, most of the first floor done. There are a number of machines that are incapable of being updated, so we have to replace those. So we're continue to push out on the other floors. We have all second floor and third floor to go. Any new machine that does get deployed will be on Windows 11. So we have 70 to build for the RHC when we get into there, so they'll all be Windows 11 to start with, as well as we move, and any consideration is only on the current side. We also on Thursday this week, in 2 days, are putting our new wireless controller into production. So that will all be additional features to the wireless access, plus its the one that is currently in production is into support here in the next month or so. So it'll be maintain consistency there. A couple construction notes up on Med Surge, the west hallway that we've been working on forever. We do have occupancy. We got that yesterday. The med gas was certified. The fire marshal came in and gave us occupancy of those rooms. There are a few items that have to be fixed before we can consider putting patients in. The goal was to have that all done by today or tomorrow. That's not going to happen. The reason for that date was we need to, as part of the ongoing project up on inpatient and med surge, the flooring and the ceiling in front of where the new nurse's desk is going to be, we need to close off the northwest wing. So we have to have those rooms available to us. We currently have 13 rooms, and when we take 9 of them out, this will get us 8 back. So we'll be down to 12 for a couple days. So that's looking like it'll be next week that we'll close off the northwest wing to get everything moving forward there. The rural health clinic, as Kim said, is progressing quickly. All of the flooring is in all of the provider offices and some of the outside exam rooms. The furniture is all being placed, so the nurses' stations, everything there are in place before the flooring can go down there. They've been painting, they're doing paint and touch-up. There is some sheetrock that needs to occur around the elevator and the stairwell on the northeast corner. The reception area has had its furniture placed. We want to get that up and operational as soon as we can, because that does affect some of the changes that need to occur going into the existing rural health clinic for some updates there and some movement of staff. So things are progressing there. The existing elevator, as Kim said, has been down for 4 weeks. They continue to progress and update the interior and the workings of that elevator. We do have some electrical upgrades that have to occur to bring it up to current code. So the parts have all been ordered. We're hoping they'll be in later this week, early next week, so that we can get that all updated and then get that open within a very short amount of time. Do you have any questions on any of the constructions going on? All right, thank you. Oh, and then the next set, sorry, going the wrong way here. There have been, about a month ago, we were asked to do some evaluation on the slides. They are pretty rusty and on the platform and the stairs. It's tough to see in this picture the condition of that, but I think most everybody has seen it on a different committee meeting. But this is the platform of the slide. You can see this whole, I'll use this, the whole area here is rusty. These are two of the supports, and we did have a company come in and give us this an evaluation called Splashtacular. They were the entity that we purchased the slides from originally and did the installation. So as part of their review, you know, we took the pictures. They said these pillars are actually in pretty decent and good shape. But the rest of it, the platform and the stairs here, you can see coming up along here, they're questionable, have some visibility, you know, aesthetic concerns. There's question also about stability on the structure long term. But anyway, they came and gave us some recommendations. And they not only looked on the inside, but they also looked at the slides on the outside and actually crawled down the slides to look at the condition inside of them. There are a couple of minor nicks that have to be updated inside there, as well as some caulking in between the joints. So, Todd.
I just wanted to talk a little bit about where we're at right now with the wellness center across the street. As of January, we looked at the last 5 years. Membership has kind of been level with the last 5 years as far as memberships and members. And if we go to the next slide, Jeff. Right now we are averaging about 1,328 memberships per month. The highest month has been January of this year, which was 1,401. The lowest month has been October at 1,258. And a lot of that's because the pool has been closed. We have some people on hold. We have people that membership ran out that they're waiting for the pool to start up again before they rejoin. So we're expecting that to go right back up. And then the average monthly member has been 3,530. And once again, the highest month has been January, where we got 3,707 members. And in the lowest in October were 3,326. Another thing that we have seen is the decrease in non-members coming in and seeing the facility or using the facility. 85% decrease in kids usage and about 30% decrease in adult usage. So we're ready for that thing to get open and get going again. Member visits per year, right now, as of today, we're at 65,824 for member visits, 7,824 for non-member visits, which is about where it ends up being 73,600 and some. We're estimated about 90,000 visits this year, which is a little lower than what we're used to, but a lot of that depends on our pool being closed these last couple of months. So we're hoping to get that up and going, and knock on wood, hopefully next week that thing will be up and running. So another thing that we have going on over across the street is our Live Well program, which is our physician referred program across the street, which is designed to improve health and quality of life. Right now, since January, we've had 88 active members in that program, 30 active right now. So we actually have 30 in the program going right now. The remaining of the 88, all but 5 of them have become members. So we're pretty excited about that, to have that many come in. Pickleball's been a big hit lately. We have been doing Monday, Tuesday, and Thursday for pickleball, and we just added a Friday morning ladies only because they were all wanting to play, and for a lot of them, they're a little bit more aggressive than the men, so they like to get and do their own thing. So we added the ladies only, so we don't have any trouble going on out there in the court. But that's been a big hit across the street. We do have three courts going a lot of the time, especially on Tuesdays and Thursdays and the Monday evening. So
I think last week of Saturday was added also.
yeah. So we've been adding whenever people want to come in. We've been trying to add that so that we get more people coming and utilizing that area. Right now we have 18 land exercise classes going on, and then as soon as the pool starts up, we'll add the 6 water classes again. So we've been busy over there trying to keep people happy and keep them coming while the pool's been closed. So we're excited to get that thing back open and running. So that's just a little bit about what's going on across the street. I wanted you guys to see that before we actually went any further with what we're asking for the slides.
So with Spectacular, obviously, we asked them for all the options that we can have, and the best one that we've come up with is a retrofit, restoration. So what that all would entail is the platform and the stairs would be replaced with a new material that probably gives us another 15, 20 years worth of life to them. The supports, as I said, they said they're in pretty good shape. They would be refurbished, which means they'd be sandblasted, all the rust removed if there is any, rust-resistant paint, primer put on, and then paint to the current color. Also then to refurbish the slides. So they would go in and fix those little chips and recaulk and bring them up to the level that they need to be. Like I said, they were pretty minor. They're only about 3 or 4 chips and a couple joints. So keep those going. And then they also check the pumps, ensure that they're operating properly. Total cost of the retrofit is $177,350. We did obviously inquire about replacing entirely new, which was just short of $500,000, and then also removing, which it's $50,000 to remove it, which sounds good, but what we could not get in time for the board meeting is all of the repairs. So the electrical, to remove the electrical, to fix the walls, to fix the exterior. Really felt that it was, we couldn't get those numbers, and it's from all the work and everything that people like, really feel that the slides are needed. Another thing is, that was recommended obviously by the Splashtacular was a maintenance program. We didn't have that prior. Annually, it's just short of $14,000. They would come in on an annual basis, inspect all the slides and repair them as needed. So if there's a chip, they would fix it right there. Obviously the caulking, update that. Inspect the leaks, identify those only if there was a leak in the pipe. Obviously we would probably know prior, but and take care of that. And then overall cleaning inside the slides so that they're working properly. I know that Todd's staff a few months ago, actually got in on their hands and knees and waxed the slides, got down to the bottom and went back up and sat on towels and took the wax off and got them going again. So that they would supervise and ensure that they're working properly. Like I said, the gel coat, remove existing failed or weathered caulking, install new, buff and wax the interiors. Something to keep those slides up in tip-top working condition. They're also, I believe in the retrofit here of the $177,000, there are a couple items wrong with the little kids play area that were included to repair on that. A couple chips in the slide, a couple rust spots that they would take care of. But then also to maintain and keep that play unit up to date is additional roughly $6,500. So with that, we would like your approval to retrofit the slides.
But there is no safety concern if the slide's the current ones at this point, correct?
No.
I think that's important that we tell everybody that.
Yes,
So
that is
know
correct.
that everything is still safe and sound.
Yep.
Yes.
This is preventative. going
This is,
forward.
yep, it is.
We did have discussion, quite a bit of discussion at our Finance Committee meetings and Building and Grounds Committee meetings over the last week. And so I think there's kind of in line with this recommendation from both of those committees, so.
I move approval to refurbish the slides and to do both service programs.
I'll second.
Okay, we have a first and a second, all in favor?
Aye.
Opposed, same sign. Motion
When will
carried.
that work take place then, Jeff?
We need to get it scheduled. I think Todd and I need to work together and what is the optimal time? Is it, call it late spring when people are starting to get outside? Is it early summer? Is it January, February, which probably not, so we get people to use that. So it's gonna be the appropriate timing on that and we'll figure out when that is. It is a 4 to 6 week process. And there may, in talking through with the rep at Splash Tacular, there may be a couple days they request the pool to be closed just for the work that they are doing. But we have to coordinate and schedule that and understand why is it they need to close the pool. Maybe it's an area we can close off that they can't get to the back, but the rest of it's all up and running. So a lot of coordination needs and understanding needs to occur. One other thing, a quick update on the pool. As we, the ductwork, all of that has been completed. The scaffolding that was put in, dirt dropped into the pool, so they've been working diligently to get that all cleaned up. But they did install supports across the large beams going in there, and so it's a 3-inch rounded pipe that they have attached all the supports of the duct to, so there's no sharp corners and edges to it. They all were stainless steel straps. Any of the straps that were there that were still in good condition, they left just as a backup. So there are probably twice as many straps on that system than what really need to be. But all was done and it looks good. And so as a result, we're hoping, after the cleaning and we did some whirlpool work, that next week everything's all ready to go for the next long duration.
Awesome, thank you, thank you. Next up, Christie. We've heard a lot of financial talk today already, but Christie's got a little more to discuss with us, so we'll let Christie take over.
Do you have them pulled up?
Yeah, do you want to skip me already, or
Well, Barry,
moving into next year?
well, Barry, no, we'll go back to you, yeah.
Well, I'm not going to go over the health partner stuff. We're kind of getting to the time here that we need to be moving on. But just real quickly, I would just mention that our strategic planning process continues, and we have 6 teams that are working on several items that have come out of that process. So we will be presenting to you at the December board meeting kind of the result of all that work that's been done over the last year. So we'll have that for you at that point. I've asked all those teams to be done by the end of November with their work on those teams. Other than that, we are going to have Dr. Kelly Anderson start going to Audubon a half a day a month starting in January. So she'll be going both to Audubon and Manning a half a day per month. They would love to have her more, but that's as much as we can give them at this point. So that's a good to get that added, and as we try to increase our OBGYN presence. I think that's all I need to go over. I can go over this health partners thing next month, so. Yep, okay.
Do you have consolidated or the, okay. So just to try and kind of briefly go through September. So this is the first 3 months of our fiscal year that started July 1st. So as you can see, between September of 2024 and September 25, in almost all areas there, we're seeing an increase in our services. The only caveat to that is the average daily census is still is down to 6.49 and 8.11 last September. October has been extremely busier than that, so we'll see some increases in that coming up in October. Year-to-date, you can see there that our outpatient visits have been up 1.8%, which is where we want to continue to see those growth, as Jeremy presented. I would say our emergency room visits, they've been up 7.5%. I would say why we didn't see that increase last year is we were still in the temporary and moving to the new location. It looks like that increase is just coming to us this year versus as his other clients came in last year. Surgical procedures are up 8.7%. Physician clinic visits are down year-to-date by 1%, slightly. There's a little over 100. Behavioral health is up 7.3%. Our average daily census is down 17.6% for the year-to-date. Births, that is based on the timing of when that all happens. We are down to 29 compared to 35 last year. Expected to see that come back again, 17%. Our operating income has increased by 14%, and our operating expenses have increased 9.2%. So we've seen a pretty significant increase there in our operating gain. Our non-operating has decreased about 46%. That's a combination of using our reserves, our investments, to pay for our construction projects. We don't have those earnings there, plus we have a decrease in our property taxes because of the ambulance service this year, so that would account for those decreases. And our net income from all sources is, so far for the first 3 months, is $2.1 million compared to $1.7 million last year. So I'm still seeing a 23.8% increase in our bottom line at this point in time. There is an additional 4-year comparison there. You can see it's services in all areas continues to grow or stay consistent. Again, average daily census, which is pretty industry standard wise. Births, you can see there we had a high year last year for the first 3 months compared to this year. And as you can see, we saw that increase in our revenues between 23 and 24 when that Medicaid directed payment program kicked in. So we continue to have strong financial reports this year and look to keep that up. Any questions? There is a lot of financial information today, so.
No, it looks great. Appreciate it. Looks real good. All right. Next one will be into the consideration of the approval of the new CEO contract. Just a quick.
We have to approve the financials.
Oh, yeah.
I'll make a motion to approve the financials.
Somebody over there seconded.
First and a second, all in favor?
Aye.
Opposed, same sign. Motion carries. Just a quick overview of the CEO, new hiring. We started this in the spring, basically in April, signed a contract agreement with Whit Kiefer, and they've assisted us in finding a new CEO. So the board's pleased to announce that we have a signed contract, and Mr. Kyle Mangner from Ellenwood, Kansas, is going to be joining us January 1st. So everybody's had a chance to look at that contract. Is there any questions, concerns, anything to bring forward before we approve it? All right. Can I get a motion?
I'll move to approve contract with Bellman.
Second.
First and a second, all in favor?
Aye.
Opposed, same sign. Motion carries.
Thank you to all of you that worked hard
Yes.
as committee members and chairs of that group, so thank you.
Barry, do you have anything else?
So we're just looking at maybe combining the November, December board meetings. So we're looking at December 16th as the date. I don't know if does that work for everyone? Check on that. An alternative would be to do it on the 9th of December if the 16th doesn't work.
Is that the Tuesday?
Yep, Tuesday at noon.
That should work.
Yep. All right.
That's it.
Yeah, if there's anything else, can I get a motion for adjournment?
I'll move to adjourn.
First
Second.
and second, all in favor?
Aye.
Opposed, same sign. We're done.